helpful, all-encompassing,
Unity.
Compassionate.
Community. Informative.
Fabulous.
What's one word to describe APA? Interesting.
It's a vibrant and active community of mental health professionals that means a lot to many people and is leading the way for better mental health across the country and the world. We're here at the annual meeting of the Premier Psychiatric Association and you're watching APA TV. Welcome back to day 4 of APA TV here in America's busiest city. And we've been busy too, putting together a program about community of psychiatrists, the communities we serve, because getting together is key to mental health. On the show today, we'll discuss how psychiatrists are honouring Indigenous wisdom and culture in promoting resilience and recovery.
We're trying to do better in incorporating the history and the effects of historical trauma. We just need to have more outreach to our communities.
Look at how climate change is impacting communities around the world.
Climate change is coming and we only have a finite amount of time to take care of it. That's really scary for kids to hear.
Having the time and resources to slow down and really take the time to look at the root of people's troubles.
And finish up our journey around the world with 2 more groups doing great work in the field. And where can you watch it? On screens around the venue, in select NYC hotels, on the APA meeting site, virtual platform and app, and on YouTube and X. First though, a session that brings together young and old to find what it's like to be a child of a psychiatrist.
We just had a session on children of psychiatrists. We've been doing this since 1998. We started this, Leah Dickstein and myself, trying to figure out if we were doing anything badly to our children as psychiatrists. And over the years, it's been one of the most fun and rewarding workshops. We always have standing room only, and we always learn so much from the children and their parents.
So I'm in 7th grade, 12, and my mom is a psychiatrist.
I am a senior in college, and my mom is the psychiatrist.
So I am a 2nd year clinical psychology PhD student, and my father is a psychiatrist.
I wanted to share my story because I think it's important for people, especially psychiatrists who have children, to understand how they affect their children, but then also to build a community of other children of psychiatrists.
I've never really seen other kids who are kids of psychiatrists. Finding that community was nice, and also just getting to share that story in general and just share a different perspective that not everybody can experience, I think was nice.
I didn't really have the chance to speak with many children of psychiatrists growing up, didn't really know many, so yeah, it was cool to just be able to share perspectives and hear from each other and just kind of learn more about how it has manifested for other people.
I think I gained a better understanding of my own emotions and other people's emotions and how to interact with others because my mom kind of taught me that from a young age. I just knew a lot of the terminology that psychiatrists use when a lot of young kids don't know any of that.
I think it might just be the empathy, sympathy, things like that, and insight. Just when I'm feeling sad, it's not always just okay, let me help you think of solutions, but it could be she knows and she just sit and give me a hug or scratch my head, or if she knows I just need to vent it out. So I think that's pretty nice.
I think that being a child of a psychiatrist really pushed me to take mental illness seriously and to be very compassionate towards others, to try not to sidesweep their problems and to really be a source of support for others around me.
I was looking at going into social work, mainly to go into advocacy, because my mom is in psychiatry and in the advocacy world. She kind of put me on that path to sort of work with people?
I think it's definitely on my list. I think what I really want to be like in the science range. I do really want to be like an archaeologist or climatologist though.
I think I just knew for a fact that I wanted to do something related to mental health and helping people dealing with mental illness. So I realized that psychology was more the path for me, but there's so many overlaps and it's really fun to be able to share with my dad and just to like learn and share from each other.
Let's head to Hawaii now, where the Department of Health is working together across the community to meet the critical need for early childhood mental health support.
Aloha from the Office of Wellness and Resilience. Hawaii's state legislature passed a law in 2022 that created the first statewide Office of Wellness and Resilience in response to the community's recognition for a collective effort to address trauma-informed care. The mission of our office is to strengthen our state systems and services using healing-centered care principles as strategies to make Hawaii a trauma-informed state. We break down barriers that impact the physical, social, and emotional well-being of Hawaii's people from keiki to kupuna. Since the Maui fires last year, we have been working to help coordinate the mental health and wellness response. Becoming a trauma-informed state will help alleviate some of the impacts of trauma and build resilience in our families, communities, and state workforce. We look forward to working with the Department of Health on the Project Launch grant, helping to address the crisis by focusing on the wellness and resilience of our youth here in the islands.
Medical assistance in dying is a topic of intense debate in North America, and one which can involve psychiatrists in a number of ways. From assessing competence in decision-making to deciding eligibility for people with mental illnesses. To discuss this more, I'm delighted to be joined by Dr. Rebecca Brendel and Dr. Maria Okendo. Thanks very much for joining me today.
Thank you.
And thank you very much for giving up your time for this interview. So let's kick off. Who can access medical assistance in dying in the US and Canada, and what are the eligibility criteria?
Well, in the United States, there's a growing minority of states that allow for medical aid in dying, although some states, including Oregon, don't have a residency requirement. So technically, anyone in the US could travel there to access this. And it's generally in the US available to people who are terminally ill and have a diagnosis of a terminal illness and who have consulted several times with a physician about a request to get help with dying.
Similarly, in Canada, you have to have a terminal illness, and it also is the case that you have to be a resident of Canada and eligible for their national health insurance. In addition, you have to have capacity to consent, and you have to have given permission in writing and verbally, but there must be a 15-day waiting period between the first and the second request.
What role do psychiatrists play?
Well, psychiatrists play a number of critical roles. First of all, in the United States, and for now in Canada, people cannot access medical aid in dying for a psychiatric illness. And psychiatrists need to be sure that the desire to die is not the result of a mental illness, such as depression. The second thing that psychiatrists generally do are they're often asked to assess whether individuals have the ability or decisional capacity to choose to opt for medical aid in dying, as opposed to going along with treatment for the course of their illness.
To add to that, I think that a critical thing is that even though psychiatric illness cannot be the sole underlying medical condition, it is the case, research has shown, that individuals who request medical aid in dying, 40 to 60% of the time, do have a psychiatric condition. So the percentage is not trivial.
I know in Canada they were looking at making medical aid in dying available for psychiatric illnesses, I believe, and have put that decision off. What are some of the ethical considerations when making that decision?
So I'd say that, number one, the issue around capacity and the impact of psychiatric illness on individuals' perception of reality, even in a condition like major depression, which often is accompanied by a nihilistic, hopeless type of feeling. that can very much cloud the individual's perspective about whether their life is worth living or not. And of course, a symptom of major depression is suicidal ideation. Right. So making the distinction between a reasonable, reasoned, logical request for aid in dying and suicidal thoughts is very tricky.
Yeah, I would definitely agree with that. And you know, one of the things as psychiatrists that we experience every day, day in and day out, is really the extraordinary clinical and legal authority to intervene to prevent people from ending their lives as a result of mental illness. So when it comes to having to distinguish from that mindset and that default position, which is a good one, right? So suicide is perhaps the worst outcome of mental illness. We also have to shift the paradigms in which we think about and distinguish desires to end life.
Another aspect that certainly takes my breath away is, as physicians, we have a duty to preserve life, but we also have a duty to alleviate suffering.
Right.
So how do you make a determination about which one of those is more important? And in fact, some ethicists argue that you actually do more good if you are helping someone end suffering
right.
who doesn't have a terminal illness, because you're preventing more suffering than in someone who has a terminal illness and they are likely to die within the next few months.
Well, how do you deal with that ethical consideration?
Well, I think the Canadian example is a good one. You take your time and you really think it through, and you come up with ways to translate between the conflict in values and the different values considerations and policies that are clear in the implementation. And I would suggest err on the side of life, because states and physicians have obligations to preserve life as a default. On the other hand, we have to really understand that there's a diversity of experiences of life and of suffering that we need to take seriously. And to say that people suffer more with physical illness than mental illness also fails to recognize how devastating mental illness can be over the course of a life and in terms of suffering.
Well, thank you both very much indeed for joining us this morning. We really appreciate it, and so much to consider there, so thank you.
Thank you.
Thanks for having us.
The impacts of climate change are all around us, but the toll it takes on mental health is sometimes harder to see, and communities suffering the most can be the hardest to reach. Let's take a look now at how psychiatry is evolving new approaches to meeting these challenges.
Last year on August 8th, 2023, 4 separate wildfires ravaged through Maui. It affected the towns of Lahaina and Kula, so my neighborhood was one of those affected by the fires. I had to manage, my clinical duties while simultaneously tracking down these fires through satellite images to tell my mom when to evacuate. So it was a very traumatic experience, and I'm still kind of grappling with what had happened. It's still been very recent.
There are both direct and indirect ways that climate change can impact folks' neurobiology, folks' mental health. The increase in fires directly impacts your brain because of the smoke inhalation, because of the particles that are being inhaled.
On mental health, the impact wasn't felt immediately at first, just because people were in survival mode that first month. People seemed to be really resilient immediately, banding together, bringing supplies, food and water to the people that were displaced. It wasn't until tourism opened back up just mere months later that the hurt really started to be felt. The wounds were still fresh and the ashes didn't even settle at that point. A lot of people have PTSD symptoms, nightmares, and somatic symptoms, pain, fatigue, brain fog, and there are just not enough psychiatrists to handle the thousands of people that were affected on Maui.
Climate change affects us all, and there's no community that is safe from the effects of climate change, and especially its effects on mental health. That being said, vulnerable communities are oftentimes the most affected, and vulnerable communities are going to be the ones that are going to have the least ability to change their circumstances and to address their mental health.
I think a lot of what we can do is at the child psych level, because a lot of kids are growing up with this rhetoric of climate change is coming and we only have a finite amount of time to take care of it. That's really scary for kids to hear. I grew up hearing that. So I think having child psychiatrists address those fears and talking about it with children to kind of grapple with it, give them the language to deal with it and talk about it with their parents, to really deal with that at the level that it starts when you're growing up.
There's plenty of things that we can do even as individual psychiatrists within our practice, for our patients, for advocacy. I think for a lot of folks, climate change can seem overwhelming, but I want to remind folks that there's also reason for optimism. And oftentimes, in the face of adversity, that's when we thrive and that's when we can make the biggest impact and make the biggest difference.
There are over 574 federally recognized tribes in the US, representing a diverse set of communities which also have many shared challenges. To discuss the mental health concerns of Native American communities, delighted now to be joined by Dr. Monica Taylor-Desir. Thank you ever so much indeed for joining us today.
Thank you for having me.
Maybe we could start off. Tell us a little bit about your work.
Definitely. So currently I am at Mayo Clinic in Rochester, Minnesota, where I primarily do assertive community treatment, where I go into people's homes with severe mental illness. But prior to coming to Mayo Clinic, I worked with tribal communities for 16 years as their psychiatrist. Sometimes they're only psychiatrist in a community, and also provided a liaison between Native Sovereign Nation and state services. And then my most recent work was as the chief medical officer and only psychiatrist for a community.
What are some of the major challenges in American Indian communities?
Well, American Indians have one of the highest rates of suicide of any racial ethnic population. But also, as we've seen an increase in the opiate epidemic, we've also seen a huge increase in opiate epidemic and opiate deaths in Native American communities. Aside from those two, we also really want to consider how historical trauma affects mental health and mental health conditions. And as we are working with Native American communities, it's really important to remember that they're sovereign nations and they have data sovereignty. So as we're doing our research, that we're partnering with them and also saying this is your information and your work so they can continue to build.
How well has the psychiatric community as a whole stood up to these challenges?
We haven't done the best job. So, when I was in training, I never heard anything about the high rates of suicide in Native American populations. I think we're trying to do better in incorporating the history and the effects of historical trauma and mental health needs. And then we just need to have more outreach to our communities.
What about affirmative care? Why is that the right approach?
During my session on Wednesday morning, I'm joined by Mary Russell, who is a Navajo psychiatrist and one of our board of trustees. And she'll be talking about affirmative care, which looks at a person's unique experience, takes into consideration their culture and also their strengths that have allowed them to get to where they are right now. And so all of those really are an appropriate approach to working with any cross-cultural community, but definitely with our Native American communities.
How can psychiatrists use the wisdom within the American Indian community to further their work?
So the Native American communities have put together like a declaration of wisdom, which I absolutely love, and they have recognized what they need for their communities. For persons that are practicing in Native communities, it is really important to approach with cultural humility and just learn and respect that they've had hundreds of years that have helped them to survive and thrive, and we need to partner with them.
How well represented are Indigenous people within the psychiatry profession, and why does that matter?
So we know that we can get better clinical outcomes for patient-physician concordant relationships. Native American psychiatrists in the United States only make 0.4%. We need to really work to increase the representation of our Native American psychiatrists.
I guess my final question then is, how do you do that?
So definitely working to provide experiences for Native Americans that are interested in getting into the sciences. And I will also be joined by Lala Forrest, who is an Indigenous woman who is in training at Yale Psychiatry residency program, and she'll be sharing some of her own experiences and recommendations on how we can get more Native American, Alaska Native psychiatrists.
Well, thank you ever so much indeed for joining us. It's really fascinating, so thank you.
Thank you very much, appreciate it.
Next up, the Austin Riggs Center provides the space and support patients need to understand their problems, find their voice, and make their way forward.
The Austin Riggs Center is really named for Austin Fox Riggs, who is the founder of that place. And we're located in the Berkshire Hills of Western Massachusetts, nestled in these hills in small town New England. And Riggs is a pretty unusual kind of a psychiatric treatment facility that really is for those patients for whom other treatment hasn't worked.
One thing that makes me excited about this place is the opportunity to slow down and do deep transformative work.
I think we really stand for a way of working that meets the needs of a world in which we've recognized that it's not simply that genes cause disease, but really there's an interaction between genes and the environment. We're also looking at how to adapt Riggs to the future and help some of these patients for whom other treatment hasn't worked, and that's what we're here for.
The APA Foundation plays a key role in supporting mental health across the country, and it's always an absolute delight for me to hear the latest on their great work and to hear the latest on the Mental Health Care Works campaign and more. So I'm absolutely delighted to be joined by Dr. Raul Andrews and Dr. Tina Kim, one of the Foundation's fellows. So welcome. Thank you both so much for joining us today. Raul, can we start with the Mental Health Care Works campaign? Yes, so how's the first year gone?
It has been a fabulous year, it has been a rewarding year, and it has been a learning year. We started the Mental Health Care Works campaign with one goal in mind, to move beyond the statement, there is no health without mental health, and make sure that we start prioritizing our mental health, just like we prioritize our physical health. In the first 100 days of the campaign, we had achieved over 32 million audience impressions. We didn't even think that was possible in the history of the foundation with all the great work we had ever done. As I sit here today, we're over 242 million impressions. People want help. They want to find out how to get help, and we have to be there if they make the call.
Those are amazing numbers, aren't they?
They are amazing.
So what do you put that down to?
First of all of the APA enterprise. This is the first time they've ever said, we're all going to do some important work, and we want the foundation to lead it. 2, we've matched an air game with a ground game. So what's happening is, not only do you see our public service announcements, you see our commercials, you see our social media, but we also do field events in community. And we've actually expanded our fellowship program so that we're able to work in community, so we're meeting the patients, we're meeting the family caregivers, and we're meeting the policymakers where they are.
So that's year one. How does it go from here?
So we're pivoting now. What we're really going to continue to focus on is awareness and literacy, so that our clinicians are not talking past our patients, and our patients feel like they're being heard and being a part of the treatment plan.
So tell us a little bit about the aims of the fellowship program.
So one of the things that I think is the hallmark of APA and the APA Foundation is that the future of the House of Medicine and our branch of the House of Medicine is only as good as we invest in it. And so we invest in a pipeline program where we bring resident trainees to a Vanguard program. We're celebrating the 50th anniversary of the APA Enterprise hosting the fellowship program. We've gotten permission from both boards of APA and the APA Foundation to do the first major expansion of the program since the 50 years that we've been hosting. So we opened a community leadership program. And so we brought in 13 trainees, including Dr. Kim. They're in community, embedded in an experiential activity.
So Tina, how did you get involved in the fellowship program?
Yes, I heard about this great opportunity from one of my mentors, Dr. Sidney Hankerson at Mount Sinai. He said, Tina, we have this opportunity where you can work in a community clinic, which is the Hope Center Harlem for me, and you can be a community diversity fellow, which means I've networked with other trainees across the country, and we're working very actively on projects. So I'm on the school-based committee, which means we're trying to really make mental health, again, as Raul said, really an everyday thing and start young. Both of those experiences have been really fantastic. I've learned a lot and I've met a lot of wonderful people. I think it's kind of the start of a great career and path for me.
And would you encourage others to get involved the same way as you have?
Absolutely. And you know, one of the things I really loved doing was actually going to the APA Federal Advocacy Day. I think it's really easy as a trainee to kind of feel like a cog in the wheel. You're just learning the system and learning how to do it right. But we also have really valuable ideas to bring to the table. Right? We're on the front lines, seeing folks, seeing what works and what doesn't. And it was really encouraging to see that a lot of my ideas and a lot of my thoughts were taken very seriously. People want to hear from us. And I really encourage people to have their voices be heard.
Obviously, the foundation is doing some great work and having a major impact. What happens next?
So one of the things we've got to continue to do is get the word out that mental health care works. But I think as we pivot to action, you know, we do recognize that there's still a growing number of people at all ages and at every stage who don't either know how to get help, they're uncomfortable or are scared to go get help, or don't think they need help. I can handle this on my own. And we gotta continue to promote the campaign, but more important than anything else, particularly because of the work that we've introduced, where 988 is a core component, the helpline is a core component of everything we do. We're gonna save some lives because of this campaign.
It's been an absolute pleasure to speak to you both, and best of luck with the campaign and the foundation in next year. So thank you ever so much. Thank you.
Thank you so much.
Thank you so much for having us.
Really inspiring work there from the APA Foundation, wasn't it? Now, as we come to the close of yet another year of the APA annual meeting and APA TV, we wanted to get out there and ask, how does APA help you help your patients?
It helps me help my patients by being open to a broad scope of exactly what psychiatry is about. Not just the medications, not just the therapy, but how it impacts people's lives, including our own.
It helps keep me up to date on new findings, new advances.
It helps me identify knowledge gaps in my own work and have resources to pull from when I need to. I actually just graduated med school a couple days ago. I'm really looking for just ways to think about psychiatry and ways to think about how I want to practice medicine.
I've been going to this meeting since the beginning of my career, which is a very long time ago. Some of the things that I've heard at these meetings have totally changed the way I practice.
Being able to feel comfortable and part of and situated within that community, I feel like I get to feel comfortable learning more, reaching out to other professionals, and in the long term collaborate to be able to support my patients.
There are so many topics, so many sessions, so I'm going to implement what I got today, so back into my practice.
It also connects us with our peers around the United States and around the world, because we can also learn from them.
Well, as they say in Hollywood, that's a wrap. It's been another fantastic year of insights into the wide world of mental health, and it's always such a pleasure to see the psychiatric community come together in the most exciting of cities. There's always more to watch though, and in the coming weeks we'll be adding extended interviews with some of our top guests to the APA TV playlist. And where can you watch it all? You can still watch on screens around the venue in select NYC hotels, on the APA meeting site, virtual platform and app, and on YouTube and X. Next year brings the annual meeting to yet another bustling metropolis, Los Angeles. Be sure to take back what you've learned this year, put it to good use, and we'll see you next year on the West Coast.